Good afternoon, everyone, and a warm welcome to the AMRIT Grand Challenge AGCJanCARE Reimagining Healthcare Delivery Touching a Billion Lives, supported from BIRAC and implemented by IKP Knowledge Park. Today's webinar is on access to primary healthcare in tier 2 and tier 3 cities and rural settings. So basically, this is the fifth in the series of our webinar, 8 series webinars. And the flow of today's webinar is as follows. For the first 10 minutes, we have Dr. Viswanathan Dupatla, Assistant Vice President IKP, speaking on an introduction to AGCJanCARE Grand Challenge and a welcome address. And then from 3:40 to 3:50, we have Mr. Mukesh Malhotra, CEO, iHub Anubhuti, speaking about the overview of the AMRIT Grand Challenge AGCJanCARE. Then from 3:50 to 4:10, we have Mr. Raghu Dharmaraju, President Art Park, speaking about reimagining healthcare delivery. And then from 4:10 to 4:30, we have Professor B.R. Shamanna, Professor at the School of Medical Sciences, University of Hyderabad, speaking about the challenges and gaps in healthcare access and possible innovations. Then for the next 10 minutes, we have Dr. Sandeep Kapila, co-founder and CEO of Swasth Foundation, talking to us about opportunities for healthcare innovations under the access to primary healthcare arena. And then for the next 7 minutes, we would have our chairman and CEO of IKP speaking about the digital health platforms for healthcare delivery. And at the end, we would have question and answer sessions after the end of all the talks. So please keep your questions to the end. So with that, I would request Dr. Viswanathan, Visu, kindly take over. Thank you.
Very good afternoon to all of you, and warm welcome to all the partners and speakers. Today's session is about access to primary healthcare in semi-remote and remote settings. Very briefly about the program. So in this program, a total of 75 innovations are being supported, 60 for the early stage with a 10 lakh rupees grant, and 13 late stage and 2 advanced stage innovations. And the innovations that are aligned with National Digital Health Mission and the Ayushman Bharat will be given preference. There are broadly 6 technology domains are being supported in this program. And going to the focus area, so when you are filling the application, there will be very specific boxes to choose. There is an option to choose more than one, but we request you to choose a very specific one which fit into the domain exactly. So coming to the focus areas, the first one is access to primary healthcare in remote and semi-remote settings, solutions for improved community outreach, health data collection, predictive analysis, and digital learning in medicine, solutions to enhance patient compliance, data privacy, storage, security solutions, data-driven modeling to enable pharma and biopharma innovations development. And the broad timeline is the call is open now, and the last date is 31st March for receiving the applications. By June 1st, we will also start evaluating, and the reviewers' comments and those things will be received. By July 1st, you will be informed about next process, and by August 15th, the final names will be announced. So in this program, along with funding, there will be additional support given by partners of the AGCJanCARE from industry, from investor, incubator, hospitals, academia, to take the solution to the next level. And just a brief mention about technology partners. So we have Amazon Web Services, MathWorks with us now. And these technology partners will be providing their domain-specific expertise to take the solutions to the next level. In a series of these 8 webinars, today we are having the 5th webinar, and all the webinars are available in the YouTube, and we will share the link for the previous webinars. Feel free to look at the first version, means the first seminar of the same one in the chat box. And the next one is on 2nd March. With this, I would like to thank everyone for partnership, and any further queries, please write to AGCJanCARE at IKP Knowledge Park. Over to you, Sri Krishna.
Thank you, Visu, for that. Now I would request Mr. Mukesh Malhotra, CEO of iHub Anubhuti IIITD Foundation, to give us an overview of the GenCare Grand Challenge. They are also the GenCare partners. So just a brief about Mr. Mukesh Malhotra. He's currently the CEO uh, of iHub Anubhuti, and he has more than 25 years of diverse experience in finance and strategy management in multiple industries. His core areas of expertise include starting new ventures, sustainability and impact assessments, developing, initiating, and acquiring new businesses. These are just a few things that I'm just mentioning about him. He has a BE from Punjab Engineering College and an MBA in business economics from Delhi University. Over to you, sir, please.
Thank you. Thanks, Shri Krishna. And I welcome everybody over here on this webinar. And before I talk about GenCare, I just want to take a few minutes about talking about I have Anubhuti and what is it that we are doing and what kind of impact that we are trying to make over here. Now, and there's a mission of a government of India, which under the DSA, which is a NMICPS, which is a national mission on the interdisciplinary cyber physical systems. So what the government has done is they have created these 25 technological innovation hubs across India. Now, primarily, it's a very similar to Stanford kind of a model. So I don't want to say that we are a VC in a government setup, but yes, it's a much larger than that. So we fund the research projects, we fund the startups, etc. And I'll come to that. What are the things that we are doing? Now, if I look at a high level, the objective is to make iHub as a hub for research, entrepreneurship, and innovation. And primarily, these are the areas which are cognitive computing and social sensing. That is something which is, the centered, and all our domain areas are centered around this cognitive computing. So the areas, the sectors that we are investing and we are funding the projects. The first one is the health. The second one is education. Then there is sustainability, and then there's a legal information and processing. In fact, if you see quite a lot, in the last few years or so, there's quite a lot which is happening in M-Health and digital health, etc. Sustainability also is kind of picking up. Legal information processing also, last 4.5 years, a lot of things have started, but it's here to catch up on this one. And education, we've already seen a lot, but from a public research perspective and all, I think that, this segment is something which is moving up now. And I have Anubhutis, has been set up, so what we're trying to do is we're trying to create this entire ecosystem wherein there's a collaboration between industries, between academic institutions, between the government agencies, startups, industries, PSUs, ministries, etc. And so that we are able to solve their problem and make this organization sustainable. And so I talked about the technologies, etc. So primarily our focus is on fundamental research, on application research, on product development and computational support. We're also working towards knowledge exchange and training. Skill development is a very important part of that one. And of course, establish collaboration, not just with Indian universities, but across outside India also. Till now, in the last, so I joined here around 8.5 months back or so. In the last 8.5 months or so, there's been a couple of things that we have done. We have started funding of the 28 projects under the 4 areas that we talked about, which is the health, education, legal information processing, etc. We have committed funds close to around 8.5 crores on that one. These will happen over a period of 3 years. The work has already started on that. People are working on that. So what we're also trying to do over here is that once these projects, and these are the projects, take the shape wherein, there's a POC which is over there, the proof of concept. Then we plan to, get the higher funding also, interact, get in touch with the VCs, etc., get in touch with the angel investors, or so try to commercialize that so that, their technological products can come and the IPs and the patents can also come in. We have also started the fellowships for the PG and the UG students over here, and the startup with the Barrick call is already over there, and I'll talk about it after this one. There's another startup call with the IIITD IC company, which we are starting in the next month. So here, unlike this Barrick GenCare, where primarily we are talking about health, the other call, the startup call that we are planning to launch, that will be across all the areas that we talked about, the 4 or 5 different areas. So this is there. There's another important project that we have launched, which was setting up the Medical Robotics Center. We did an inauguration, and there's an MOU signing ceremony which happened with another hub of IIT Delhi. which is IHFC. So triple IT's hub, which is us, and IT's Delhi's hub, which is IHFC, we have come together to form a medical cobotic center, MCC, which is, I think, the first one in India, if not in Asia. So idea is to develop this a state-of-the-art center, and there are two parts to that. The first one is the robotics center. Robotics are the robotics where we plan to use that for training the doctors and resident doctors, etc. The second thing is we also plan to fund and help all those projects which are into digital health, health, telemedicine, etc. So hopefully and we committed a lot of that investment for that fund. So this is all about the iHub Anubhuti. And coming to the startup call with Bharat, this JanCare, I already, the first speaker had talked about that there are three categories of here, which is the early stage, the late stage, and the advanced stage. So, as a iHub Anubhuti, most likely we will be going for the late stage and the advanced stage projects also. The reason being in the early stage innovations, there are a lot of the individuals also over there. And the way our business model is, we are going for the projects and we are going for the startups which are more in a, we're already, which are in the form of a company. So ideally, even in an early stage innovation, if there is project which seems to be very promising and which can take the form of a company or so, we are willing to look into that also. So these are the ones primarily late stage and advanced stage projects that we are coming up. Out of the entire 10 crores, we have committed somewhere around 2 crores for the different projects or so. And it will be so unlike the way Bharat is doing that, where it's more of a nature of a grant, here we'll be going for a equity route. So I think it is important for the, in fact, it's an advantage for the startups and the innovators, because on the one hand, they are getting these grants in the form of a from the Bharat. At the same time, they also have the additional option of getting the equity in this particular JanCare. Now, talking about the JanCare program, the first speaker already talked about, major leads into the telemedicine, health, digital health solutions are there. So if I were to look at, there are 4 or 5 broad categories wherein, this entire JanCare program is all about. The first one is, access to the primary healthcare in a tier 2 and tier 3, and also in a rural setting. Now, if we see that there's a lot of the work in the health which is happening, but, primarily it is being centered around the metros. But thanks to technology, there is a lot that can be done at a much more cost-effective way in terms of reaching out to a tier 2 or a tier 3 cities, even the rural towns, etc. There's no reason that somebody, a doctor in Bangalore or in Delhi, cannot treat a patient remotely who is there in one of the remote parts of Chennai, of Tamil Nadu, or Karnataka, or maybe a UP, or one of the villages near Meerut. The second is about the patient compliance. Here we are talking about entire digitizing the systems. For example, it could be a patient tracking system, it could be the health record management, it could be the enrollment system, etc. So that the idea is to get a end-to-end information of a patient, and wherever the patient goes over there, in one click, the person should be able to get that, and there should not be any problem in accessing that data. We are also looking the intervention in the health data collection, predictive analysis, digital learning in medicine, etc. I think predictive in the times to come, what I feel is that predictive analytics in the healthcare is something which is going to change the lives of people over here. Just to give an example, if there is somebody who is going for a running, for an early morning run or so, and all the indicators are there which are attached to the sensors, and these are again being monitored somewhere, and suddenly there's a spike in the heart rate, etc. And which could which could be the call for a heart attack or something like that. But if there is if somebody is there tracking those signals or so, and there's some alerts which can really go, so that before something happens, there's an ambulance which can come in. So this is all about predictive analytics. Personally, I'm very excited about developments in this. One of the issues which is happening with the increase in technology is about the data privacy, storage, and security solutions. It is something which is which could be a cause of concern for many people, that data, health data, which is something which is extremely personal to somebody. What if there is could be some kind of a breach which is over there, or if the data gets shared. So trying to implement those solutions where we have federated learning models. We have a this entire ecosystem where the data doesn't get kind of a misuse by anybody, and also creating a framework and a model to make sure that we are able to use the data. That's another one. And then there's also solutions for the improved community outreach, which is it could be related to say, for example, supply chain technologies. It could be related to logistics, resource allocation tools, etc. So idea is to create this entire connected healthcare system for here. And finally, I would say the data-driven modeling should be enabled. It should enable pharma and the biopharma research development and innovation in creating a difference to the society. So primarily, these are the 4 or 5 areas that we are looking for, and we are more than excited to be a part of BIRAC, NASCOM, MIT, DBT, IKP, etc., in being a part and making a difference to the lives of people over here. As you already said, all these solutions are in the innovations. That program is being aligned with the Ayushman Bharat, National Health Digital Mission, etc. And most of those programs and initiatives and startups innovations which are aligned to these 2 broad programs, definitely the preference is going to be given to that. I think more or less I covered almost everything over here, and yeah, that's from myself. Thank you.
Thank you very much, sir, for that.
Yeah.
Giving a very nice outline of what iHub Anubhuti does, and also about the details of the JanCare Amrit Grant Challenge itself. Thank you very much. And without much delay, I would now invite one of our expert speakers for the day, Mr. Raghu Dharmaraju, to speak on reimagining healthcare delivery. Mr. Dharmaraju is currently the president of AI and Robotics Technology Park, or ART Park, which is a not-for-profit foundation promoted by Indian Institute of Science. He has over 20 years of experience in conceiving and scaling institutions and innovations. He has held several senior leadership positions and has built a path-breaking portfolio of 8 AI innovations. He has also established Wadhwani Institute for Artificial Intelligence as an institute of global repute. He has a BTech from IIT Madras, MS Engineering from University of Massachusetts, and an MBA Marketing, Venture Capital and Sustainable Global Enterprise from Cornell University.
Yeah, thanks everyone. I used to be judging these BIRAC and Grand Challenges stuff until about 4 years ago, quite regularly every year. But it's been, so it's a nice way to come back into the fold and start participating again. Quickly about myself, actually, probably the most important elements of my journey are the fact that I've been a medtech entrepreneur in the past, launched a path-breaking medtech company called AMRIT, one of the earliest ones that actually scaled. I scaled it across 20 countries, helping more than 3 lakh babies across public and private health systems. But it taught me a lot in terms of the difference between coming up with an idea to actually having impact. So there are lots of lessons from there, and I'll summarize a little bit of that. The other thing, primarily what I want to focus today is how technology can actually play a role in reimagining health journeys, and you'll see what I mean by that. So let's say it's 2030, somewhere in remote rural India, and Shanti wakes up with some cough, going about her daily chores. She's feeling unwell, right? So she grabs her phone, launches Sahayak. Sahayak asks her how she's feeling. Obviously, this is actually happening in Hindi, since this is rural MP, but of course for ease of understanding for wider populations, we are sticking with English here. She says, I have a cough. Sahayak asks her for permission whether he can listen to the cough, and after taking permissions, listens to the cough. Also asks her about some symptoms, and then there's an AI screening engine that uses the cough sounds, reported symptoms, and also Savdhan. Remember, this is 2030. So there's this population disease surveillance platform that provides contextual information. Using these 3 sources, the screening algorithm computes a low urgency score, but turns out it also predicted that potential causes are COVID-29 and TB, and both happen to be watch list diseases. Now, what does that mean? It means because these are watch list diseases, even though she is not able to travel because of any number of constraints, we all have those constraints, right? Sometimes it's difficult to go to a clinic, even if it's just a kilometer away, and in remote rural areas, that's not always the case, right? So Sahayak prioritizes a consultation for her through the unified health interface. For those of you paying attention to the National Digital Health Mission, this is an important construct that is coming to place. Think of it similar to email. We are not wedded to one particular email program, right? Anyone can send email to anyone, communicate with each other. So imagine a set of protocols that allow anyone to connect with any health service providers, be it doctors, pharmacies, or hospitals, right? So in 2030, that's a mature ecosystem. And also turns out PMJ has expanded in 2030, hopefully, to include primary care, at least in certain situations where there are watch list diseases and public health concerns associated with them, right? So Sahayak finds her a doctor, and she chooses as per her convenience, and and automatically the doctor's schedule is managed, right? Of course, the local care team, ASHA and ANM, have been informed, and the ASHA confirms that she is able to actually be there for the consultation. Calls Shanti and just says, don't worry, I'm going to be there, right? Shows up a little bit early, uses the med phone that ASHA has to do some basic vitals measurement, and also helps the ASHA to use a DigiLocker and give permission for relevant health records. This ensures there's actually continuity care instead of just episodic interactions with various health providers, right? Which was often the case back in 2022, right? But this is 2030, so there's continuity of care, right? And the doctor uses one of the UHI Unified Health Interface partners to log in, check her records, and at the other end, ASHA is using eSanjeevani for a teleconsultation, right? And after a few follow-up questions, the ASHA then uses her kit. This kit includes both wearables and sensors, as well as molecular biology solutions that are used at the front lines. And after measuring a few things, doctor decides that she actually needs additional care. So a mobile screening and diagnostics van shows up. Now, the point of this is really that the world is changing, right? 60 to 70% of households already have mobile phones. And that gap will be mostly closed. We have good digital infrastructure policies, regulatory frameworks coming into picture. And e-commerce, and there's lots of new digital, physical, and human resources, right? And this is all creating opportunities to leverage acceleration in science and technology. Broadly, if I were to put it in 4 categories, I'd put it in sensors, ranging from just the phone itself to lab in a chip and other ways of miniaturization. AI/ML, ranging from language, as you've seen in that, all the way to screening, diagnosis, and decision support. There are digital biomarkers, and of course, there are other novel biological, what we know as biomarkers in general. And of course, the very rapidly accelerating space of bioinformatics and genomics. And leveraging this, we really can imagine healthcare, as I've shown. Now, a couple of things I want to just call out to innovators and entrepreneurs who may be listening. The thing to really think about is, now there's several things that technology was doing in this vignette, in this example. But I want to especially point your attention to the fact that innovations were embedded in the system's workflows, right? Often this ends up being a gap, right? After years of judging this, it still surprises me about the fact that we just assume that we are building something and it's going to be adopted, right? So really pay close attention to how your innovations are going to get embedded into the system's workflows, right? In fact, I think technology can enable several paradigm shifts. Currently, healthcare is mostly sick care. We need to go towards health and wellness and prevention. We have very siloed interactions. We need more continuum of care and follow-ups. COVID has really shown this. We are over-reliant on hospitals and labs and specialists. We need to go to the homes and front lines and augment with tools and decentralize. Our population level interventions are currently reactive. So population scale intelligence, proactive strategies are an important element, right? Late diagnosis is something that's very endemic for us. So tools that really bring screening prediction to the front lines. Not even diagnosis. Diagnosis usually has a higher burden, right? But even if you say just this will play a big role. Heavy burden of reporting and entry is one of the scourges of our health system, right? So if you can create technologies that have intuitive, easy data capture, converting subjective, entries into objective measurements with very minimal hardware, that those sort of technologies will go a long way. And of course, we need algorithms in which data becomes useful at the front lines and not just simply for reporting, right? And we are so these are all some things I wanted to call out. Few lessons I'll just end with. Please do get on the ground and validate the problems you propose to solve. Constantly, I see this as a challenge. And try to be very clear with the first settings that you want to market to. There's a huge difference between a tertiary care hospital in Delhi versus tertiary care hospital in Delhi versus, let's say, a rural setting. But forget about even that. Going from a Fortis in Delhi to going to some back alleys of Khan Market, that's already very different even within Delhi. So be very clear about the users and the settings, right? Low cost is this overemphasis on low cost sometimes really surprises me and often reflects lack of understanding that low cost does not always lead to impact in low research settings. It needn't be the primary basis for the value of your innovation, right? Also remember that if it's a device, for example, taking especially hardware folks have a real difficulty with this, so I'm mentioning this. But your cost of goods sold, your cost of making it may be one, but by the time you get it to some place through channels, etc., it's very common for it to go to 2.5x and 3x. In fact, without that, you probably will not have your channels for selling and servicing. So remember that. Also remember that you may have a perfectly designed device from a user centricity perspective, but in health, often there are multiple stakeholders. Beneficiaries could be different from users. The choosers could be different, and the payers could be different. This especially is the case in public health settings, right? And the journey you got to remember is that in early days, really focus on building robust evidence and bring experts on board as your champions and advisors so that you make the right choices. But as you move forward, it'll be very foolhardy to ignore economics and the ultimate fact that adoption of new technologies happens through experience. So finding those sandboxes and partners to create those experiences are going to be very important, right? So with that, I will conclude. Art Park is the AI and Robotics Technology Park at IISc. We operate at the intersection of startups and venture capital, governments and nonprofits, and research and academia. We have both in-house innovation efforts going on and also both invest and support startups. So if you have interesting and worthy things to do ping us. IKP and BIRAC are amazing ecosystems. You'll find a lot of support, and we look forward to supporting this initiative. Thank you so much. And I'm happy to take any questions if there are, but that's up to the organizers.
Sir, we thought that we will have all the questions at the end. And thank you very much, sir, for very nicely summarizing and giving us a schematic flow of how things would work in a 2030 situation, the importance of unified health interface, the DigiLocker concept, and also the importance on user perspective. Thank you very much for that, sir. Now I would invite Professor B.R. Shamanna. He is currently the professor at School of Medical Sciences, University of Hyderabad. He has held several senior level leadership positions and was involved, in fact, in developing two large WHO collaborating centers for prevention of blindness in India. He is very well traveled and published extensively and has been widely acclaimed as an immensely motivational teacher. He has an MBBS from KMC Hubli, an MD in Community Medicine from AIMS New Delhi. He has two diplomates of National Board degrees for himself, and he also has an MSc in Community Eye Health from University College London. Over to you, sir, please.
Thank you very much, Krishna, and very good afternoon to everybody. I would appreciate if I've given the host rights to share my screen.
Sure, sir. Just a second.
Yeah. If you can make me.
Yes, sir.
You have the rights, sir. You please go ahead and share.
Yeah, sure. Do I? Yeah, thanks.
Yes, sir.
Is my screen visible?
Yes, sir. Yes, sir.
Thank you. Thank you so much, Krishna, and also the fact that my association with IKP goes back quite some time, and probably we worked with Deepanita quite closely in terms of developing the technologies for public health initiative. So, and like my previous speaker, I've been involved in some of the grand challenges and reviews, etc. And thanks for the opportunity to come back again. What I'll try and do is for all that that I'm more of an academic, I'm not an innovator. So I'll put that as a disclaimer first, and also tell you that the fact that a lot of this information which I'll be presenting is you can't probably sort of thank everyone who's been part and parcel of this presentation, but I can tell you for sure that most of it and all of it is very well validated, authenticated, and to the best of my ability, it's peer reviewed. Given that fact, I will probably take you through something which I thought was very, very critical, because I will look at it in terms of innovation from the end user perspective rather than from an innovator's perspective, in terms of really looking at what is the context and what issues exist when we are looking at innovations, and especially looking at the challenges in terms of reaching these innovations or scaling and scoping these innovations. Then talk a little bit about what we call as implementation research, which probably is the cornerstone of bridging the gap between knowledge and practice. And I think it's very important for us to understand that this is something which we need to look at in terms of the innovators. And I will probably give you a few cases or few examples in terms of what implementation research we've been involved in and why it's important for us in terms of innovations, and probably end with the directions for innovations more in terms of just giving you a sort of bucket list in terms of saying that where we need to innovate if we need to go and reach people who need them most or reaching the unreached. With that particular background, I don't have to re-emphasize the fact that we are probably living in a globalized world with the assumption that globalization would have reduced the gap between the haves and the have-nots, but as a matter of fact, it's proved otherwise. And testimony to the fact is the evidence which is readily available. But what's important for us to understand when we are innovators is the fact that the interactions, the more and more becoming a global village or homogenization, and that particular spillover has ultimately led a lot of things which are both good and which are probably not so good when it comes to healthcare delivery. And that is where I want to pitch this particular presentation in terms of saying that globalization has been quite a sort of, what should I say, in terms of a new or a 3-decade-old sort of thing within our country, at least in terms of looking at population health. And when you're looking at innovations, please look at these determinants. I've tried to give a visual appeal in terms of saying the institutional determinants, in terms of the economic determinants. Don't forget the end user sort of perspective and technology, and especially what we have seen is there's a very, very focused and a tunnel sort of an approach for innovators in terms of the development aspect of technology, uh, with little emphasis in terms of the end users. And I was very, very, I'm happy, fortunate, and also I thank my self for being part of an earlier presentation of Raghuji. And I know, how Embrace came in and how it was actually scaled and scoped up. So the socio-cultural determinants, and especially looking at it from the population perspective, or the so what I'm trying to tell you is whichever technology or whatever technology or innovation you want to develop, please take into consideration who's going to ultimately use it and how is it going to affect the development aspect, which means right from the development stage to the implementation stage, or to the permeation and to the acceptance stage. It's important for us to keep that perspective in mind in terms of the social and cultural determinants, and not to forget the economic and environmental determinants in terms of how it exists within a particular ecosystem, because one size can't fit all. And we may, as innovators, we may have to think of how we can actually make sure that the technology is also sort of customized. Today we talk about technology and we talk about generalizations, etc., etc. But at the same time, in the field of healthcare, as much as you would like to have groups and you would like to have technologies reaching out to large number of people, please do understand that each individual prefers technology which is customized to him or herself. So personalized in the broader ambit of generalized is something which innovators need to think of in terms of really this thing. So that's precisely why I thought it was important for us to look at globalization and its impact on innovators and its impact on technologies, and especially if you're talking of digital health technologies. It's just to tell you that there's so much of impacts with respect to globalization. I'm very happy to send this presentation along to be passed on to all the people who have been part of this. But without much ado, I would probably look at innovators and technologies looking at these aspects. And I did see 4 E's, and I wanted to add a couple of more E's in terms of really looking at issues of equality, issues of equity, looking at economics, which Raghuji did present. Of course, justice and liberalization, etc., becomes important when it comes to innovations, as said. And when you're talking of equity, whether it is require innovations technology in terms of looking at vertical equity, whether you're looking at horizontal equity, whether it is in terms of being fair to fair, unfair to unfair, or whatever it is in terms of looking at technology, I think it's very, very important to keep these in mind. Another couple of more E's, and this is always a challenge, and this is something which we have seen as both a challenge and an opportunity when we are looking at reaching the unreached, or sort of reaching our services to the final common denominator in terms of how can you be effective as well as being efficient. And this is a matrix which you need to actually work out for yourselves in terms of the innovations or technology per se. And given this fact, I thought it's very, very important for us to understand that this is the context in which we live in, the mechanics of failure, the overburdened health system with the healthcare programs, and the health system itself not being able to sort of sustain or support the issues with respect to it. In the context of this mechanics of failure, I guess it's important for us to look at technology from that particular perspective or innovations. And that is where I thought it's important to sort of contribute this particular aspect of what we call as the bridge between knowledge and need, which we call it as implementation research. And when we are looking at implementation research, basically we are talking about, say for instance, a well-validated, reliable, extremely good technology is developed, and it can be developed in a good controlled environment, a lab, an industry, etc., etc. But what does it do when it goes to a real life situation? how can you translate what you developed in a particular controlled situation to the real life situation? And that is where it's a challenge in terms of taking proven interventions and implementing them in the real world, and especially across diverse settings and across healthcare systems in terms of it. I also want to tell you that there are many interventions which already exist, but these interventions have not been able to actually reach the people who need them most. And that is where this aspect related to how do you develop and how do you innovate and how do you make sure that it reaches the people is something which you need to look at when you're developing technology as well, or innovation. So the bridging the gap in terms of implementation research, which is emerging as probably the most important thing in terms of addressing healthcare challenges, is what I would like to propose as people who are going to be innovating. And as a base, where do you start? Innovators probably would look at the starting point, would also look at how do we make sure that the innovations or the things which we develop are in areas where there is a lot of priority and where it strengthens our system towards probably universal health coverage or the sustainable development goals, and for which we have the 6 building blocks of a health system, or what is called as the World Health Organization's health systems approach, which consists of the service delivery initiatives, the workforce in terms of human resources, information, products and technologies, and financing. And don't forget the accountability issues with respect to leadership and governance is as important as development and implementation of innovations and technology. So it should address issues related to access, coverage, quality, and safety. These are very, very key things if you are desiring improved health, improved system responsiveness, looking at risk reduction, both social and financial, and of course, the aspects related to being effective as well as efficient. So given that fact, what I'm trying to tell you is when you're looking at innovations and when you're looking at technology in terms of the innovations, please take into consideration the contextual factors which I presented already. The interface in terms of really looking at or understanding the reason as to what can be achieved in theory and what actually happens in practice is something innovators should think on their feet very, very quickly. I see it because as entrepreneurs, as innovators, failure, then success is something which all of us know and all of us can allude to. But the fact is, this generation is a very different generation to the generation which was 5 years ago or a decade ago, in terms of really looking at the theory part, and in terms of really implementing it in real life situations or real world situation is something which we need to look at very closely as well. So variety of approaches need to be used there. Like I said, there is no one size fits all, but for an innovator, for somebody who's going to look at technology, I think the most critical aspect when it comes to innovation in terms of really going ahead is asking the right question. And when I say asking the right question, it's not the evidence in the evidence way which we probably think of. Evidence as academicians, as the scientific community, is more in terms of the proof, more in terms of generating that replicable model and all those kind of things. But here, innovators are working in very, very complex research areas, and this reflects the real world. As much as evidence is important, it's also equally important for us to look at how do we continuously adapt in terms of making technology, contextual, in terms of making technology reflecting the daily life situations or real life situations, or not forgetting about the future in terms of contributing to the present, is what we look at in terms of also generating this particular question and implementation. So all this is the theoretical aspects in terms of how you go through the models and how you go through the current, from the current state to the desired state. I'm not going to spend a lot of time. All this is available As I said, I can send you the information and you can look at it in terms of converting theoretical aspects into real practical implementation thing. But do understand, it's a cobweb. It's in terms of really looking at multiple complex issues. And when it comes to healthcare, you're looking at the bench, you're looking at bedside, you're looking at clinical care, you're looking at what we call as brass tacks in terms of the real world field situation on which you don't have control. As innovators, as technologists, we don't have control over what happens in real life situations. It's the people for whom you meant have the control over whether they accept it or don't accept it, or whether it impacts them or doesn't impact them, etc. And I was very pleased when Raghu sir did mention quite a lot of things in terms of the economics, the costs, and all of those kind of things, which does matter to the final common denominator. So my teacher and even Krishna's teacher, Dr. Venkat Narayan, who leads the diabetic research at Emory University in Atlanta, Georgia, earlier talked about how important it is to transform correctly available knowledge for useful measures in everyday clinical and day-to-day life. And what he called earlier was translation research to what we call today as very quickly, I'll just go through a couple of cases in terms of saying, we raised this question in terms of looking at why is there increased cesarean section rates in the state of Telangana. As a matter of fact, as a state, it's probably the highest when it comes to the South Asian context, comparable to rates within Brazil or within Chile, within the South American context, where the overall rates of cesarean sections in a state in Telangana is about 60.7% as per the new National Family Health Survey results. But you will be surprised when you look at the rates in private facilities. 8 out of 10 deliveries, 80% in districts like Karimnagar, Jagtial, etc., etc. How does this make sense to somebody who's an innovator, for somebody who's going to develop a technology? That's something which we need to really look at in terms of making sure that how do we promote people undergoing more normal deliveries? How do we promote that we need capacitate facilities? How do we make sure that we keep people engaged in terms of an interface between the provider and somebody who's a pregnant mother? So all of this gives us an opportunity in terms of saying, people going to a public facility understand that they see lots of people at different points in time. Somebody does your antenatal checkup, somebody does your delivery, somebody does your postpartum, somebody takes care of your kid. But when you are in a small facility, a first referral unit, a primary health center, etc., etc., it's probably the midwife, if they are there, which are not there in most of the states, or the nurse, or the ANM, or the primary health center medical officer, etc., etc., who has to cater to a lot of people and at the same time carry out certain functions, etc. So we did that, and we were very fortunate that probably this led on to for us to look at the grand challenges exploration at a global level in terms of hitting a Gates funding for this particular project, which is ongoing, called Rejudge, where we are looking at how do we reduce rates of non-medically indicated cesarean sections, and where technology plays a very important role, or where innovation plays an important role in terms of developing probably an open access education communication system, which in this case, we are looking at lawyers and judges to reduce litigation in terms of looking at it. And then based on this particular project, we will look at co-development or co-collaborative projects, working with communities, working with people who have been aggrieved, or working with people who've had cesarean sections, although they did not deserve one, etc., in developing the innovation. So I'm trying to tell you the cycle in terms of looking at improving access to and use of safe and appropriate cesarean section. Do we have opportunities for innovations here? Dime a dozen, plenty. And if you really look at the illustration which I've shown you in the top right corner, you will understand that all of these are areas particularly linked to something which looks at this particular question in greater detail, and where we have a lot of opportunities for a thing. Now, coming to another very important thing, within the university, we work with, there's something called as the Dr. Reddy's Labs, Dr. Reddy's Institute of Life Sciences, where one of the questions we try to answer is there a sustained way of releasing micronutrients, especially targeted at, mothers, probably people who require special nutrition and all those kind of things in terms of looking at this particular thing. We've come up with a nanotechnology patch where the chemists, the nanotechnologies have fabricated, have come up. But we told them that now who is going to take this patch? How are you going to make sure that this reaches the people whom you think should reach? Because you're looking at prevention and control of anemia. So we have looked at acceptance, and very interesting results are there. At this point in time, I can't present to you the acceptance survey results, but just to tell you, we have taken the perspective in terms of really looking at the acceptance aspect, whether it's a mother, whether it's an urban mother, whether it's an illiterate mother, whether it's somebody who has special nutrient requirements, etc., by saying that, look, this patch can deliver micronutrients for a week. It just has to be applied like a plaster, right? And this will release, sustained release for a week. But the most interesting thing about this particular thing is it will not completely obviate the need for taking, oral tablets or injectables, etc., but it will supplement your diet, etc. Are you willing to take it? Yes, probably yes, when it comes to reasons like, I take iron tablets, causes a lot of constipation. When I'm pregnant, when I have constipation, it's going to be a bigger problem. And, injectables, especially iron and, those vitamin B12, etc., very painful. Actually, I don't prefer one. I get an abscess and all those kind of things which people tell you. So what I'm trying to tell you is, as much as we are looking at innovation and technology on one side, also make sure that you take the perspective of the end user in terms of really scaling, scoping, and all of those kind of things. We have a lot of information with respect to tribal health within the state of Telangana, especially with my anthropology colleagues here. We have questions which are very, very ready. Now, if you want to innovate, we have the information in terms of saying what is the context and what is the sort of innovation which we need to do. If you're going to be talking about, say, for instance, the Soligas, the Koyas, the probably Savaras, etc., depends upon what kind of primitive and vulnerable tribes you're looking at, and particularly the vulnerable tribal groups which exist in some of the districts in, say, Adilabad, some in Mahabubnagar, etc., or North Andhra Pradesh, Vijayanagaram, Visakhapatnam, Srikakulam, etc. So the first step, and what Sir said as evidence, is probably that information which we have ready. This forms the foundation for developing innovations in technology. So to conclude, I think it's very, very important to identify the particular problem, analyze the determinants, and when I say analyze the determinants, don't forget the socio-cultural determinants. It's a combination of a lot of methods which you need to do. Then your solutions, implement your interventions, and don't forget to evaluate the outcomes in terms of the plan, do, study, and act approach. Lastly, all this fits in very well with our mandate in terms of the universal health coverage and the sustainable development goals, where we are looking at equality, equity, quality, and financial risk production in terms of efficient health system, financing mechanisms, access to innovations which all of you will develop, delivered by people who are trained and capacitated to deliver them. All this looks at greater sort of an approach which is multidisciplinary, interdisciplinary, working with a lot of agencies and institutions in terms of really making a dent in terms of the universal health coverage. So as much as key questions are important, the logical endpoint in terms of conceptualizing, implementing projects or innovations and institutionalizing them is very important. At this point in time, with respect to implementation research, it's coming up as a very big field, but at the same time, you have to understand that there is a lack of understanding, a lack of investment, because it's very, very complex. People don't understand the thing. What is required is probably a 360-degree perspective in terms of the approach. Any guesses for why I put this photograph, and anybody wants to allude to what or where this photograph is from? Anybody? Krishna, you can try as well.
Yes, someone has already answered rightly. Yeah, I knew you have already told this to me. Somebody has answered.
Wonderful. Yeah, that's wonderful. Yes, it's from Bhutan. Reason I put Bhutan?
It has got highest happiness index.
Precisely. The whole aspect related to human development index has gone out of the window. We are now talking of what's called as gross national happiness. And Bhutan is one place where a lot of efforts in terms of really looking at thing. And this place is called a Zong. Zong includes both the civilian administration as well as the spiritual administration. Both of them work together. Probably meditation, spirituality helps them in terms of their happiness, but I'm not going to speculate what it is. Thank you very much. Thank you.
Thank you. Thank you very much for very nicely telling us about the challenges and gaps, and also giving us live examples from the actual projects that are ongoing at your end, be it the cesarean sections or the microneedle or the transdermal patch, which again are plenty of examples for innovators, the prospective applicants. For them, it is definitely a lot of food for thought. So thank you very much for that. And without further delay, I would now invite our next speaker to give us a startup perspective. I would invite Dr. Sandeep Kapila, a co-founder and CEO of Swasth Foundation. So Swasth Foundation is a not-for-profit social enterprise committed to health and joy for all. So he has worked, Dr. Kapila has actually worked in McKinsey and company for 7 long years before starting this Swasth Foundation. So he holds a BTech in computer science from IIT Bombay. He has an MD in alternative medicine from the Indian Board of Alternative Medicine. He has 2 years of law studies from Mumbai University and a diploma of associateship from Insurance Institute of India. And he also is a certified professional life and health coach. So I think it really nicely blends from the last picture of Dr. Shramanna. And over to you, sir. Yeah, please.
Thank you, Krishna. Yes, so yeah, it actually sets me up, Dr. Shramanna, very well. Firstly, I just want to clarify, I'm not a doctor. So I'm a computer science graduate with, as you saw, multiple other things in the healthcare domain. So it sets the happiness question sets it up very well, because at Swasth Foundation, our vision is health and joy for all. And our motto is also to be Swasth Raho, Anandit Raho, that is be healthy, be joyful. And that's because we see a very, very strong link between health and joy, where both of them sort of create a very virtuous cycle for each other. If you're healthy, you are joyful. If you're joyful, you become healthy. And that's also the spirit of, at least from our side. Just to give a quick background before I give those ideas on what can be worked on from an innovation perspective, is to give a quick, like a minute of what Swasth Foundation does and what I've been doing. So we are a 14-year-old entity, a not-for-profit based in Mumbai. We've worked quite a bit in rural Maharashtra, rural Haryana, North, and a lot in urban areas, particularly Mumbai. We run 2 programs. One is a program of a network of primary healthcare centers. We currently have 16 centers, which provides primary care in dental and general medicine, comprehensive. So doctor, medicines, lab tests, etc., all of that at less than 50% of the market rates to the urban poor in Mumbai. The second program is a Swasth Yoga Institute. This is an institute which is currently training a new cadre of integrated health professionals, which integrate the Western and the Eastern therapies. That is, with medicines, how do we do yoga and develop protocols for the same. So that's what our focus is. So coming to what I think the opportunity in rural healthcare, as we are talking of innovation, is I think the focus of that innovation should be health and not healthcare. I think this is to what Dr. Raghu was saying, that focus should be on health and not healthcare. And what do I mean by that is the focus need not be as much on healthcare, where we are trying to treat conditions once people fall ill, but a lot more on keeping people healthy. So our work in rural Maharashtra showed us that more than 75% of conditions that people had, health conditions, were all preventable. Most of them, about 50% of them, were conditions around acute things like waterborne infections or indoor air pollution. So both of those are very manageable and preventable with education and providing people with the right tools. The other 50% was chronic conditions, which are all self-created conditions because of poor lifestyle choices around diet and around activity. So both of these are now established through a lot of research that these can be prevented. And if the solutions, innovations are geared towards that, I think that would be the most efficient healthcare system for India, where we have less people falling ill and needing expensive healthcare. Because as most of you would know, that once people fall ill, the cost keeps just escalating. So the focus primarily should be on prevention and keeping people healthy. Now, for specific to me, specific things, so some thoughts that can be done and the kinds of solutions can be evaluated. These are very different than, sorry, what I was seeing upfront. So they might not fit with this innovation challenge. But to me, things like looking at solutions for water, drinking water, potable water, ensuring continuity of potable water, and prevention of indoor air pollution, and such similar, sometimes very local issues, challenges, which cause the healthcare problem, which is local to the area. So if we can figure out what are some of those challenges which are specific, these two are, at least in my experience, I have found a very common across large parts of our country around waterborne diseases and airborne, particularly indoor air pollution. That can, if they can be prevented, solutions around that, a lot of education around that, smart ways of educating, entertaining ways of educating, where you could also create a possibly a business model to make it sustainable. So a lot of education, I think that will help, and these two specific problems. The other is on chronic conditions. I think there the solution space, there is a lot that can be done around food and diet, particularly around the evidence that's coming, which backs a lot of the fundamental or age-old beliefs that are there in the Indian system. It's building confidence in that, and sometimes based on evidence also adding to that. So things like intermittent fasting, which is something which has been there in our cultures. People have just sort of thought that it's no longer a fad and look at it the other way. Similarly, using less processed food, which is being marketed more as aspirational. The West has seen the impact of processed food on their own health. Countries spending 15-16% of their GDP on trying to take care of health of people once they fall ill. But if we could prevent that, and I think here particularly there is a very good strong window of opportunity right now, because that messaging around aspiration hasn't seeped in to our tier 2, 3 rural market yet, and there is an opportunity to prevent that. And I kind of see this with this technology example of a landline versus mobile, right? So if we had healthcare is like landline, right? Do we want to provide healthcare everywhere, provide create an infrastructure around providing landlines, or sort of leap forward and get people to really communicate, which is the real purpose, through a mobile phone network? And to me, that's when we keep people healthy through some of these very basic things around diet, around physical activity like yoga and other disciplines which provide these physical solutions, mental well-being, through meditation, spiritual practices, education and specific tools and techniques to prevent issues like waterborne diseases and airborne diseases. So that would be my strong suggestion for the innovators as they are thinking about innovating for health, particularly for tier 2, 3 and rural India. Thank you.
Thank you, sir. Thank you very much for bringing that focus from only healthcare to healthcare plus health, and then that's actually very important. And you brought the issue of these are not definitely new things like drinking water, water pollution, air pollution are age-old things, but are still unsolved, and they have a major impact on health. So definitely, point well taken. Even issues like food, diet, meditation, mental well-being, so major areas for innovation. So definitely, thank you very much for that. With that, I would now request our CEO ma'am, Ms. Dipanwita Chattopadhyay, to talk on digital health platforms for healthcare delivery. So basically, I don't have to introduce our CEO. Yeah, please, ma'am.
Thanks. So thank you. I think what I heard today, and I can actually string, I don't need to talk of digital platforms. What I need to say, probably after hearing Raghu, Sham, Dr. Shamanna, Sham, I have this bad habit of calling you Sham. So, Raghu, Sham.
I am Sham for you always, don't worry.
Okay. Thank you. So Raghu, Sham and Sandeep, we have to look at the healthiness quotient, and technology is an enabler. Technology would enable and empower to give shape to the vision that we want to implement. And if we have the vision, so it is not about a technology vision. It's about the social construct, the social vision of the society that we are talking of. And how do we use technology to make that vision come true? And that is very important, because if it is technology for technology's sake, and if we think that all problems will get solved because we will implement technology without giving enough thought to what kind of world we want, universal health, is that going to bring in more equity? What is ultimately, if it is, if we are looking at a more healthy and a more equitable world, that's a happy world that all of you spoke about. What is required to make it a healthy world, and how many people being healthy makes it healthy? Who is the beneficiary? What kind of technologies are required? What kind of platforms are required to stitch these platforms to ensure that we reach out to the beneficiaries in a manner that they are empowered? It is, I think, empowering the people to be able to take their own decisions and be healthy is the best solution. Whatever we do is to enable people in that direction. I would love to talk about today Vishu put out Dr. Bhan's presentation at our IKMC in 2018. And at that time, he mentioned that he's putting a new vision for the healthcare system. And he actually was talking about a very similar kind of a design where we understand the need, what kind of society are we aiming at, and that will determine what kind of health system we build in. It's not about healthcare, it's about the same words I heard when I was hearing Dr. Bhan. All of you would know, most of you would know, Dr. Bhan passed away in 2020, January 26th, on January 26th. His he was on our board, and his lecture, this was not his last lecture. There's this last lecture thing, but this is his last lecture at IKMC. And there he was talking about what kind of worlds and healthcare as a use case. Where do we go from here? And if you're looking at the healthcare, it is about health and not about healthcare. It is about the health systems design and how we make sure that we are able to use technology for that purpose. It will be good to see, Sri Krishna, if there are questions, because we just have about 15 minutes. I can talk about the programs that the IKP Center for Technologies in Public Health had embarked upon. At that point of time, Dr. Shamana was the first group of people I had contacted, 3 of them from LV Prasad Eye Institute, who are running a rural initiative for taking eye care to remote areas. And from there, we had built it. And at that time, I interacted a lot with Sandeep. And Raghu and Sandeep, you would remember about what platforms we were thinking of building in terms of delivering healthcare. So, but that I think will not be as important today to discuss a platform, because we want to see where we use technology, and we can use technology to the benefit of the outcomes that we are thinking of. That will be the right approach, I think. So I would like to see a few questions before Sri Krishna. Are there moderated questions that you want to bring in? And then I will talk about, if there is time, I will talk about the platform that was developed at ICTPH.
Yes, ma'am. A couple of questions from the registered participants.
Yes.
So one question is, what are the unique challenges in integrating technology in rural, tribal, and tier 2, tier 3 city areas versus as against metro or urbanized areas? And also, is there a good political will and commitment to do so? I think this question would be for Mr. Raghu.
So what I would request is both Raghu and Sham to address it, because Dr. Shamana is also working on tribals. And I remember, Dr. Shamana, you were earlier working in South Karnataka, that if I'm not wrong. So that your full experience on the tribal area would also be important. But first, Raghu.
Sure. As you rightly called out, first of all, I think it's important to first define what we mean by urban and rural. India is not black and white. We know it's many shades of what rural, urban are, right? So first recognize that there are also regional challenges, right? A big city, for example, a Patna is very different from Hyderabad, right? Even though they are both big cities, etc. So first remember that. Importantly, whenever you think of especially digital technologies that have to be integrated into some sort of digital systems, public health systems generally are lacking. That doesn't mean private health systems have actually figured it out at all, right? They remain extremely fragmented, right? So the unfortunate answer is you will find this a challenge, variety of challenges wherever you go. And hence the importance to actually engage with your imagined customer, right? And actually understanding how whatever you want to do integrates with their workflows and their systems, right? There really is no way to, give broad stroke assessments, right? Political will, it exists, but remember it's difficult and progress happens not necessarily, one overnight transformation, but some great steps in some places. And if usually it's not simply saying, hey, okay, look, we have this innovation, it will go fit anywhere. There is some searching to do. And this is where I think the program that Deepanvita ji and everyone else have put together becomes important in finding the right product market fit, right? That's key, right? The stuff that I developed at Vadhani AI, for example, Telangana government was amazing, Gujarat government was amazing, but sometimes the actual acute needs were in other places. But they desperate need does not translate into immediate demand. So you got to find your path.
And Dr. Shamanna, from your perspective, because I remember it was Dr. Vivekananda, I think, that I was referring to.
The Vivekananda, Swami Vivekananda Youth Movement, which works in HD Kote area, which is in Sargur, in and around the Nagarhole, forest belts, etc. The fact is, I want to say it in one sentence in terms of what you assume as communities' needs is not their wants. When I say so, I think a lot of our innovators and people who are trying to develop technologies have something in their mind in terms of saying that this is what the end user needs. But unfortunately, what you find is what you think as the technology needs is not what the people want. It's very interesting for us, and I've been reiterating the fact that unless until you engage people for whom the technology is meant, I don't think so the technology is going to be very, very successful. I'll give you a very interesting sort of example, and at the same time, how technology can be actually, there was this a couple of things. One is the Swasthya Slate, which was developed as part and parcel of doing innumerable tests at a click of a button and all those kind of things, and it was pitched to be placed in citizen facilitation centers like the E-Seva, Me-Seva, Bangalore One, and all those kind of things. When it was tested out, it worked very well. When, say, for instance, in a place in Jammu Kashmir, etc., it got quite popular. But when they tried to place it here, the fact was, you need people to give you a sample of blood. You need people to give you a sample of urine as well for the technology to work. You're working in places where there are no bathrooms in terms of facilitating all this. And how will a technology probably work in such places? So it became such a miserable sort of, I should say it was a setback for the people who developed technology. No problem at all. Wonderful. Penetration, big problem in terms of that's one aspect to it. And another one was the device which they developed in terms of the visual inspection for cervix to detect carcinoma cervix in situ using glacial acetic acid. It was supposed to be used at a household level or at a community level, etc. But tell me where privacy is available to do a cervical inspection. It's not something which the people who develop the technology haven't thought through this process in terms of. Ultimately, it had to be done in a facility where you have facilities which you can do a pap smear with. You don't have to depend on visual inspection of cervix with acetic acid. So I'm saying technology probably is good. It has been developed with a purpose in mind, which seems to work. It's been validated, etc. But what are the social, contextual sort of acceptance criteria for such kind of technologies? And that is where, when you're working with tribes, when you're working with people who are, as much as possible, I think they look at technology as something which is alien, which is probably curbing their individual rights and fundamental rights, if I may say so. I'm taking the argument a little forward. So that is where I think it's very important for us to look at the societal end user beneficiary perspective in terms of developing technology. Thank you.
Sandeep, if you have anything to add, otherwise I'll move to the next question.
So I just wanted to say from a, I think maybe very conceptual standpoint, what I have seen is everybody needs or wants, right? 2-3 things are common. They want to be healthy. They don't want to go to a doctor. The last preference is wanting to go to a doctor or a hospital. People want to be at home and they want to be healthy. So if we have built solutions which are designed around that I think we'll find adopters, which is much easier in general, right? And more people are likely to adopt it, because that's a common for all the great things that doctors do. But people, imagine yourself also whether you want to ever go to a doctor, right? It's such a disempowering experience that I think people really don't want that. So,
but today, only today I was reading a McKinsey report where they're showing that the telehealth consultations are falling across the world because post-COVID, because neither doctors nor patients want for a little serious conditions to go through a telehealth experience, because 2D is not 3D. So they've said whether it's IRL or URL, actually you go to present yourself or you go through an URL. So we have to be very careful in terms of where we position ourselves.
Sorry, when I meant people don't want to go to a doctor, to me a telehealth is going to a doctor. So that is worse than going physical. I meant solutions which will keep them healthy.
Right.
I think focusing on those. So just my old point, I think if we focus on solutions which promise health and not just symptom management, essentially, I think that's
prevention. Preventive technologies. What other questions? URL versus IRL.
I think this question is to Sandeep itself. So how reciprocative are communities in accepting technologies for access to primary healthcare? Both, I think Dr. Shyam also and Sandeep could answer this, because Shyam also mentioned few examples related to that. So over to you.
But I think just somewhat what Vita said, when it's a necessity, they were okay with consultations, for example, when there is no other choice, like in COVID lockdown, etc. We also started teleconsultation. There was, the moment that opened up, it stopped. People don't prefer that at all, right? So when it comes to especially meeting a doctor, for transactions like getting medicines, etc., technology is good, getting reports, all that is good. But as soon as it comes to some sort of expertise, some sort of consultation, they are not okay with that technology. The other thing we have though seen in our example now, very interestingly, which we didn't expect, but during this process, even post-lockdown, we have found people are okay taking yoga classes online. So we started with yoga, which is around the message is preventive. How do you get back to health and stay healthy? So we found a lot of acceptance on people wanting to do yoga, even in the low income community. So that was surprising for us, but there people did take that effort. There was some training that was required for Zoom, but they were willing to undergo that training. So that was surprising to us, because they were giving their time for doing that. That's been our experience with using technology per se.
Krishna, the only point I want to make here, all that what Sandeep sir said is the fact that trust is extremely important between the provider and the end user in terms of whether it is a thing. So building a rapport with the community, sharing all the stuff which the community needs to know when you're developing something is equally important in terms of acceptance. I think this trust in terms of the provider and the acceptor, or what you could call the society itself, is extremely important. And trust building doesn't come naturally to healthcare providers. And I would reiterate the fact that the mindset of a provider is very different. So it's not like practicing in a clinic or practicing in a facility. It's about you're at their mercy. When you go out, you're at their mercy. So you have to make sure that you have to work in ways and means which accepts them. If they tell you subah mat aana, sham ko aana, you have to go in the sham also.
The question that I had is engineers versus biotech or life sciences people. So there has been a lot of immersion programs happening. Has that actually been able to bring better solutions? How, because the way clinicians look at problem, the way engineers, not biotech engineers, but technology people look at problems versus the way scientists, bioscientists would look at a problem, are three different lenses. And have we been able to bring that together in the last 10 years that I'm seeing a lot of immersion programs and bringing technology people? So if there is a PI, who should be the PI? My question is very directed because I am now an applicant and I have a clinician in my team. I have a bioscientist. I am a management person and an engineer. I'm an engineer and a management. Who should be the PI? And who do you think can really deliver this kind of a complex thing that you're talking of? 2-tier, 3-tier healthcare delivery. This is a question to all three of you. Just wanted to get your views.
Say something on that. So
yes, Mukesh, of course.
So before I answer that, who should be the PI? So one of the things that we are doing over here is that, we have found a MCC, which is a Medical Cobotics Center. And this is a collaboration between 4 organizations. It's between IIITD, which is a parent company, iHealth, IIT Delhi, and their hub, which is a IHFC. And the MOU is between the 2 companies to simplify this entire thing. So what we're doing is, we are forming up an MCC, which has got 2 components. One is the Cobotics Center, and the other one is digital health. So we're trying to get the engineers and the doctors together in this particular one. So
we are doing it all the time.
I could foresee a lot of ego clashes also, like the doctors will have this one. What does the engineers know about that? But what we're trying to do is, for example, suppose for an MRI, there are 250 images. And there's a radiologist who's an MD and he's an expert in that one. He will take some 20-25 minutes. And maybe engineers can design something which can take a fraction of a seconds to at least, do the first level filter. I'm not saying obviate the need of a radiologist. Just to give an example, almost 70% of these images, the solution are correct, right? The diagnosis says they are perfectly fine. In 30% of the cases, there's some kind of a problem which is over there. But when a person is doing that one, the mindset, the cognitive biases is more of that everything is fine. 70% of the thing is fine. So there could be a chances of an error in the reading. Yeah, this is what the AI can transform, and this is where the engineers can help. It's more of a collaborator, but I see a lot of these things, and so we have to be very careful in terms of getting the doctors, engineers that look. It's more of a collaborative thing. Turan, I don't have an answer to that. Who should be the PI for that?
No, it's just not about the PI. Who takes the lead? Because I have a computer science engineer and Raghu, you did computer science or mechanical?
I did neither. That didn't matter, right? I actually wanted to say what it helped that I could understand computer science as well as medicine.
Yeah.
Right. That ultimately I say you have to put your heads together and butt your heads together, right? And that's the only way good solutions happen. As far as here's my thing: if there is really not a clear agreement on who PI is, I would say there's already a bit of a problem with that team. Interpersonal relationships and those things matter perhaps as much, or in some sense more, right? Because all these things are really long journeys, right?
Yeah.
They're going to be really deep, dark days when you feel like, why the heck did I ever want to do this or get into this? Where you want to curl in a corner and cry, right? And it helps when you have at least one other person to cry with. So I'll say that forget about this, who puts PI, who puts not. No one will remember that 3 or 4 years from now. Who cares? Are you writing on your resume who was the PI on this grant application? If that perhaps matters, you're probably going to be focused in a very pure research sort of thing and not really interested in bringing solutions to market. So I know it's a very different take.
No, it's a very apt, because this is a message to students, because there are 60 grants for idea stage, and it's not just startups, students, researchers would apply. I think they need to understand 2 things that you said. They're in for a long haul, and let them choose the partners they're working with. If you part, it's fine, but till you are there, work together, and doesn't matter who is doing it.
I would highly recommend having at least one partner in crime, right?
One partner.
You at least one partner in crime, right? Because this is not a journey of one discipline. This is a multidisciplinary journey.
Very
right. That is number one. Two is you really do need the ability to sound ideas of one another, and this is not an easy journey, right? Even if you are simply writing a research paper, I know that it helps to have at least one other person to work with.
So, Shyam and Sandeep, any thoughts on that?
Yeah.
Because I know ultimately we have to see how we get the best solutions. So the teams have to prepare themselves for the best solutions.
So, just I think on completely resonate with what Raghu and you were saying, Deepanvita. Just to add, whoever to answer that question, who should be the PI? I think the PI is not based on the technical skill set. I think the key criteria for the PI, and I think the rest of the key team, will be humility and listening skills. I think those are the two, I feel like, the most important ones, being able to listen to others and having the humility to let go also at times. Because it's a long journey. As Raghu said, it's a long journey. Yes, thank
you. Shyam, anything for you to add? Because your students have to apply.
Yes, they do have to, and they have to understand that they have to be patient, they have to be passionate, and they have to be perseverant. If you want me to cloak it in 3 P's, I will say be patient, be perseverant, and be passionate about what you want to do. In terms of, I want to be gender neutral, whether you want an agony aunt or an agony uncle, it's up to you to decide in terms of saying, but I would definitely go with what Sandeep sir and Raghu sir said in terms of having a sounding board, in terms of bouncing off ideas, whether it's a proposal, whether it's a paper, whether it is a bottleneck which you find, etc., etc. It doesn't matter which background they come from.
Very good. I think that's also a good ending note. Doesn't matter which background you come from, because you can always get a technologist if you want. The idea matters, and the implementation capability, what implementation research and capability, and understanding the needs of the people you want to serve, you want to work for, is important. So even if you are from an anthropology background or whatever background, you put your team together and bring the solution to us. We will be very happy to look at out-of-the-box solutions.
Yeah. Try to bring the smartest people you can find and give them the title. And
give them the title.
And then that's basically it, right? So
yeah, absolutely. I think that really works, because I remember when Mr. Vagul, Narayanan Vagul, ICICI Bank, they got me from Mumbai to Hyderabad, and when Mr. Vagul, after a board meeting, said, Deepanvita, we have decided you will be the CEO. I said, but I don't have a life science background. What am I going to do in a life science park? He said, oh, you'll get enough scientists to help you. I said, no, I don't have an MBA, so I'm not a management person. It's all my training in ICICI. He said, oh, there are enough MBAs to help. So whatever I'm telling him, sir, I don't know this, so you can't make me a CEO. He said, you'll get people. And so what are you seeing in me that you think I'll deliver? He said, passion. He said, and your resilience and passion, and that's, I have seen. So I think ultimately, and I have still now I'm here doing IKP. I'm not left. So I think with that note, we'll end the program today. All the videos, not just this one, will be on our YouTube. So anyone can see it later. All the sessions are there. Very beautiful talk, very, very encouraging discussions. I wish I could again jump and become an innovator. Thank you all. Thanks so much. Vishu, over to you.
Thank you.